to present today a very important webinar about the ACA and addiction treatment, the implications for policy, practice, for improving access to care for people with addictions and with mental health conditions. We have the ongoing implementation of the Affordable Care Act has resulted in many changes, with still more that are in the pipeline. Behavioral health professionals and organizations must be informed of how the ACA affects addiction treatment and recovery services in order to remain compliant, as well as to provide maximum benefit for this historic bill. This free webinar dives into the issues that you'll want to know regarding how the ACA influences treatment models, patients, service delivery, reimbursement, policy, and your professional practice. Upon completion of the webinar, we hope that you will understand these 5 things. First, how has the science influenced the components of ACA and its availability for people with addictions? Second, how the addiction treatment model can and should change based on the changes that are coming through the ACA. Third, the implications of the ACA and the Mental Health and Addictions Parity Act on patient profiles for treatment-seeking individuals. Next, how ACA-related service delivery and payment reforms that incentivize rapid screening and access to treatment. And finally, what policy and practice issues, practical issues, workforce, clinical services, financing, still need to be addressed in the post-ACA world. Okay, a real quick slide of my picture, and now the webinar is produced in partnership with the Addiction Technology Transfer Center, a SAMHSA-funded cooperative agreement to help provide training and technical assistance around substance use issues. The Big Brief Intervention Group Initiative, NORC at the University of Chicago, National Council for Behavioral Health, and NADAC are all co-sponsoring this webinar. This webinar is one in a series of webinars, and we hope that you will all take a look at whether you can make some or all of these webinars, and more detail for each one of those is listed on the hospital.webs.com/webinars.htm website. On the website, you'll find access to all of these PowerPoint slides, a continuing education quiz. The recording will be up in a day or two, and free continuing education credits. If you'll notice on the right-hand side, there is a box so that if you have any questions, you can type in questions into that pane, and at the end of the presentations, we will take those questions in order, and we'll try to get as many of those answered as the time allows. So if you have any questions as they come up, also if you have technical issues, we will be monitoring it for issues with if you have any issues about sound or on access to materials or other issues. Our technical facilitator is Misty Story, and Misty is the one who makes all of this come together and work. She will be the one who will be answering any technical questions that you have, as well as making sure that the materials are available, and she will be our contact point for the completion of a very brief survey at the very end, and also any continuing education issues that you have. The first part will be presented by Tim Condon. Tim is currently a visiting research professor at the Center on Alcoholism, Substance Abuse, and Addictions at the University of New Mexico. He's involved with various projects related to the intersection of public health and public safety, prescription drug abuse, healthcare policy reform, and implementation and integration of behavioral and physical health systems. He also serves as the Chief Science Advisor to the Center for Health and Justice at Task, Illinois. Prior to joining CASA, Dr. Condon served in the White House Office of National Drug Control Policy as the Science Policy Advisor to the Director. Before that, he was the Deputy Director at NIDA and has actively pursued research in the science of addiction and its implementation into clinical practice. Tim, thank you for presenting.
Well, thank you very much, Eric. Delighted to be invited by this group of people, all of these groups that I've worked with in some aspect, one way or another over my career. Delighted to be a part of this. This is, as you said, a very important webinar. This is a very important time for the field of addictions and behavioral health. In fact, in my 30 years or so working in this, I've never been as optimistic and excited about the prospects of what we're all here to do, and that is to take care of the patient population that we're here to serve. So again, thank you for inviting me, and let me take you down a little trip of what I think has been important and how we got here. So having been the Deputy Director of the National Institute on Drug Abuse, I'm a neuroscientist by training, as some of you may know. I always start my presentations with advances in science have revolutionized our way of life in particular, but also our basic understanding, our fundamental views of drug abuse and addiction. So anybody remember, this dates me, but if any of you are out there of a baby boomer generation, you might remember this from Star Trek, and we had science fiction, and of course now we have science fact. So it wasn't long ago that, in fact, technology was being conceived of that's a reality now. This is, of course, one of the first computers ever developed. I don't actually even remember this, so this might even be when I was a child. And, of course, advances in technology and science have changed the way we use all of these technologies now. And the point here is I happen to have been privileged to be at the National Institute on Drug Abuse during the time when we had this dramatic change in our understanding of drug addiction and the effects of drugs in the brain. So many of you may remember this is from 1987. This is from our good friends, our Partnership for Drug-Free America, now partnership.org. And this is the way in 1987 we depicted your brain on drugs. This was the egg in the frying pan. It was a metaphor. Actually, it became very popular to many, many people. It became something that you might see at the beach on a T-shirt that said, "This is your brain on drugs. This is your brain on drugs with a side of bacon." It became part of drug kind of folklore. But that was in 1987. And in a very few years later, in the early 90s, using neuroimaging technology, we had this dramatic change in the way we could see your brain on drugs. And this is a picture from Breiter and Rosen from about, I think the list is from the mid-90s. And what you're looking at are functional MRI scans and looking at activation of the brain. On the top, there's three pictures of the same person's brain at different levels. When they've been given cocaine, and you see these areas that light up, the tectum, the nucleus accumbens, the amygdala, and this is the same person on the bottom when they're given a saline solution. So the point here is that the science of addiction, the neuroscience of addiction, really helped revolutionize the way we start to think and what our beliefs about addiction became. So as I said, addiction science has revolutionized our way of life and our fundamental views of drug abuse and addiction. Drug abuse is a preventable behavior. We all know that. Lots of research has gone into identifying risk and protective factors and many kinds of interventions by which we can prevent people from, especially our young people, from taking drugs to begin with. But once people become addicted, and what the researchers showed us, is that they really enter a different state. The neurochemistry changes in their brain. They no longer have the same kind of voluntary behavior they had before, and we need to treat addiction as a treatable disease rather than just as weak will and bad behavior. We know from the research then that addiction is the quintessential biobehavioral disorder. And what do I mean by that? Well, it means that it's not just about the neurochemistry or the biology or someone's genetic predisposition, but the science has showed us those are critically important. The behavior itself is something that can reinforce itself, and there's one aspect of it. And as we also know from our own experience working with people with substance use disorders and other behavioral health issues, environmental factors can play a huge role. So it's really an interaction of these three different components that make this the quintessential biobehavioral disorder. And in fact, just trying to treat one without the other doesn't give you the best outcomes. But because it's a biobehavioral disorder, it also, the science has shown us, it's both chronic and relapsing. And that's something has been one of the hardest things for many people in the public to understand. Even researchers in the past have been guilty of not understanding and trying to use what we call the acute care model. Now, this is very apropos. I think Eric and Misty know this, but this is the acute care model for a broken bone, which I happen to have suffered in early December. I broke my ankle, so I went into treatment, had surgery, and for Christmas present, I got a titanium plate and 6 tiny screws in my ankle. I got a cast on it. I'm currently undergoing physical therapy, and hopefully I'll have a healed bone and the use of my ankle and my foot will be restored. This is the acute care model. Much like physicians who give people antibiotics for some kind of acute infection. You get an antibiotic, and 10 days later you take your full dose, and the acute infection is gone. And that is how the acute care model works. But we've also tried to apply this acute care model for substance abuse, and people who are substance abusing patients, they go into treatment, and then they're released, and they're non-substance abusing patients. Well, we all know that relapse is a very real part of having a substance use disorder, and so this isn't the reality of the way we should be treating substance use disorder. But many people think that this is really the way it should work. And I can't tell you how many times when I've talked to people and you tell them that, in fact, addiction treatment can work, they actually roll their eyes roll up in the back of their head, and they say, no, it doesn't really work. And why is that? Well, because they all know somebody that it didn't work the first time, the second time, the third time, people who actually had relapses. So again, it comes from the fact that we've, as a nation, as a society, have relied on this acute care model. We know that relapse rates for drug dependence, this slide has gotten a little messed up, for drug dependence, 40 to 60%. And this is a landmark study that was published in the Journal of the American Medical Association by Tom McClellan and his colleagues in 2000. Drug dependence has relapsed rates similar to diabetes, 30 to 50%, hypertension, 50 to 70%, asthma, 50 to 70%. So you can see that the relapse rates for this chronic relapsing disorder, drug dependence, addiction, is no different than these other chronic illnesses that we treat with a chronic illness model. Addiction and other chronic illnesses have many things in common. Recovery may be a long process, may require multiple episodes of treatment, may require checkups for sustained recovery. Relapse can occur. Relapse is a reality when it comes to substance use disorder. Participation in self-help groups can be helpful to maintain abstinence. And failing to treat these chronic illnesses costs lives and money. So I always just like to use this as an example. If we treat a diabetic symptoms don't subside, what do we do? Well, a physician would increase the dose of the medication. They might change the medication that the patient was taking. They might change the treatment approach. Maybe this is just diet and exercise, and the person now needs to go on medication. Would we fail to provide ongoing treatment for a diabetic? And in fact, as a society, we've done that for addiction for a long time. We actually still, in some instances, will actually throw people out of treatment if, in fact, they relapse. We need to get over that, and we need to treat it with the acute care model, a continuing care model such as this, so where someone could be screened with screening and brief intervention, and some maybe motivational interviewing in a primary care setting to actually diagnose or assess whether or not they have a more severe problem. So we refer to a specialty care. This is what we do with all kinds of different illnesses. So, and then they in fact could then return to their primary care physician or their primary care clinic for a continuum of care, whether it be checkups for whatever. So this is really more the model that we need to adopt. So I've worked for 27 years in Washington, D.C., working on these issues, and I can't be more excited about the Patient Protection and Affordable Care Act, Public Law 111-48. And the goals of this, when enacted, were to expand coverage for 32 million more Americans, to increase private insurance through health insurance exchanges with federal subsidies for small businesses and individuals below income thresholds, and to increase federal Medicaid by covering most Americans below 138% of the poverty level. And this is the key, including, for the first time, childless adults. Create more effective, cost-efficient, and integrated care systems. Well, I have to give you some disclosures here. My first disclosure is I wanted to articulate to everyone is that healthcare reform equals the Affordable Care Act, or the ACA, which also equals Obamacare. Now, I didn't realize that many people out there in the public didn't realize that healthcare reform and Affordable Care Act, ACA, and Obamacare are all the same thing. And I didn't know this until Jimmy Fallon did an on-the-street interview with people on the street and asked them, do you want Obamacare or do you want Affordable Care Act? And the vast majority of them said, oh, no, we want Affordable Care Act. We don't want Obamacare. So it's obviously gotten a negative connotation, but in fact, these are all the same thing, and my disclosure is here. I love Obamacare. I think it's the best thing has happened to especially those of us in the field of behavioral health and substance abuse and addiction. One of the most important aspects of it that really makes my dopamine and my brain go up is the essential health benefit that's specifically laid out in the statute that mental health and substance use disorder services, including behavioral health treatment, shall be a guaranteed essential health benefit. They are one of 10 essential health benefits, and again, they're written into the law, and they're written into the law to be at parity with all of these other essential health benefits. This is terrific news for the field of behavioral health and addiction in particular. We know that substance dependence and abuse in the U.S. Really affects, this is from the National Survey of Drug Use and Health, about 22 million people in 2012. And we also know that we have a large number of people, it's probably about somewhere close to 220 million people who have little or no use of substances of abuse. So those are people that are very much we should focus on prevention. But we also have a large number of individuals, about 68 million, that have harmful use patterns. And this is a group that we really haven't focused on in the past. But now with the benefits, essential health benefits, it's something that we can take a look at. We also have about 22 million people, as the household survey tells us, who have a diagnosable substance use disorder. And that's actually about the same number of individuals in the United States that have diabetes. But in fact, we've only reached in about 2.3 million people, about 10% of individuals who have a diagnosable substance use disorder have actually received treatment for it. And that hopefully shall change in the future because of the various aspects of the Affordable Care Act. We need to focus on this group of harmful users, those who are addicted, and increase the number who have treatment available to them. The household survey also showed us that location for past year substance use for people who received treatment, self-help group was the largest, sorry for the number mix-up here, outpatient rehabilitation, inpatient rehab, outpatient mental health centers, hospital inpatient, private doctor's office, emergency room, prisons or jails. So we have still a long way to go in terms of increasing those who receive appropriate treatment for substance use disorder. Who and what will ACA provide? Well, when enacted, it was estimated that additional 16 million individuals who earn less than 138 million, 138% of U.S. poverty level will be covered by Medicaid in 2014. And unfortunately, only 25 states and the District of Columbia have actually chosen to currently expand Medicaid. Now, there are discussions in a number of other states to do variations on Medicaid expansion, and we certainly hope that that's the case. An estimated 16 million individuals with incomes between 138 and 400% of the U.S. poverty level will be eligible for federal subsidies to purchase these same essential health benefit packages from state insurance exchanges. Now, we know that had a rocky rollout, but in fact, we know that as of last night, I think the President announced that there was 9 million people that have been enrolled in these, and this is occurring in all states. So I'll tell you a little bit about what's going on in New Mexico. New Mexico chose to expand its Medicaid early on. I would point out, even though we have a Republican governor, she saw that the need in our state was so critical. So Medicaid expansion here is called Centennial Care. And after expansion is complete in New Mexico, because of the poverty level in this state, we will probably have about a third of the population in New Mexico enrolled in Medicaid. Medicaid is going to be administered by 4 managed care organizations, and in fact the state, and I have been involved in this myself, working directly with the MCOs on behavioral health requirements to make sure that those essential health benefits are on parity with other medical conditions. Medicaid expanding for SUD and treatment, medication-assisted treatment, Narcan co-prescribing, intensive outpatient recovery-oriented systems of care, peer support specialists. These are all covered under Medicaid in this state. And behavioral telehealth is expanding because we have a very much a rural state. This is very important as well. And the New Mexico exchange, which is actually, I believe, run by the feds, is up and running, www.bewellnewmexico.com, and it is enrolling individuals. Collaboration is also occurring between the Medicaid department, Division of Medicaid Medical Assistance in the Health Services Department, and the Department of Corrections on trying to figure out methods to enroll offenders prior to release from the Department of Corrections facilities. We also have an expansion of SBIRT in the state due to a grant from SAMHSA. New Mexico SBIRT expansion is working specifically on FQHCs, embedding behavioral health people into federally qualified community health centers, working in tribal facilities to do the same thing, and of course expanding health information technology. There's also, as Eric had mentioned, and I think our other two speakers will talk about, is the integration of medical and health homes with integrated care. This is essential for the ACA. Integration of behavioral health workforce in federally qualified community health centers. And this is important here in New Mexico, and it may be in your state too, because we have a large population of rural and people who actually are in lower socioeconomic states, and that they usually get most of their treatment from FQHCs. Integration of primary care into addiction treatment facilities. Well, I'm happy to say this is also becoming a reality. Here at the University of New Mexico, our university hospital's addiction substance abuse program, which actually just moved to new facilities, expanding, has two different aspects that I wanted to mention to you. One is they also have, for anybody who comes in, primary care available in the same facility. So this is not integrating behavioral health into primary care, but it's integrating behavioral health integrating primary care into behavioral health. And hopefully we'll see more of that going on too. And of course, one of the biggest challenges that we all face is workforce. And the state is working hard to do more recruiting and training, and including community health workers and peer support specialists. This is phenomenal in my mind. I'm very excited about this, but is there more? Well, of course there's more. And this affects some of our most vulnerable populations, and it's one that I particularly have spent quite a bit of time focusing on the last couple of years. 70% of the individuals in state and local jails having abused drugs regularly. And this going to jail sale sign was actually something that I took here in New Mexico one day when we were driving down the street. But this is a reality. We know that there's estimated correctional population of about 8 million adults and 650,000 juveniles. And of those, estimated over 400,000 of the adults, in fact, 5 million need treatment. And of the juveniles, 250,000 of them need treatment, and only 54,000 have actually received it. So we still have a way to go between need and actual delivery of services. Opportunities for intervention for this vulnerable population are pre-arrest, pre-trial, prosecution, sentencing. In prison, not so much, although there needs to be improvements, especially for behavioral health with behind the walls. And of course, one of the most important aspects is reentry into the community. About 2.5 million drug offenders are currently in the community, and about 350,000 are released each year. So you can see there's an incredible need. If 70% of those individuals have been involved with substance abuse, there's an incredible need for those individuals to receive some kind of treatment. So will the Affordable Care Act and healthcare reform impact criminal justice populations? Yes. Although the law, ACA, specifically excludes coverage for individuals who are incarcerated from receiving benefit, it does not appear to exclude approximately the 9 million individuals who cycle through the jail system, services for pretrial, pre-sentencing detainees, and most importantly, in my mind, is for those who are actually on probation and parole, the majority of which have been involved with alcohol and drugs. I would tell you about one example that I know of working with my colleagues in Chicago, breaking the cycle of drug use, crime, and delinquency and incarceration. 4 overarching principles: develop infrastructure to promote alternatives to incarceration when appropriate, use community correction programs to monitor and support drug-involved offenders, create supportive communities to sustain recovery and reentry populations, ROSCO, and improve treatment for youth involved in the juvenile justice system. So the ACA and blending public health and public safety in Cook County, Illinois, and Chicago is all about creating new partnerships. Cook County Sheriff's Department, Cook County Health and Hospital System, and TASK, organization which is really a specialty case management for criminal justice populations specifically related to substance use and behavioral health issues. And the Cook County Criminal Courts actually all came together to create a new partnership to provide care for these individuals. And here's how it worked. Illinois was one of the waivered states that did an early implementation of Affordable Care Act last year. And they created in Cook County what's called County Care. County care members have access to the comprehensive package of medical, mental health, and substance use treatment services, essential health benefits. Approximately 200 to 300 men and women enter the Cook County Jail intake every day, many of whom have untreated medical, psychiatric, and substance use dependence conditions. Well, TASC, in collaboration with its other partners, got an agreement to actually station TASC staff in the jail intake when people are being arrested and booked and being going through the intake process, of working with them and speaking with them one-on-one to screen and enroll them and see if they're eligible for enrollment in county care or Medicaid expansion. The project started in April 2013, and I can tell you I checked this week, and to date the TASC staff have really already talked face-to-face to about 45,000 individuals. They've filled out 11,000 applications and that have been initiated, and over 2,000 have been approved. And the partners hope that this will help result in many people being enrolled and covered, the first step, getting them the needed health care that they need. In my mind, treatment is the key when it comes to this population because it reduces crime, saves money, and improves the lives of the individuals. So where do we go from here? Well, we need to, as a scientist, I'd always say we need to advance the science. We can't have enough science to improve the treatments and the preventions, interventions that we have. We need to improve treatment, but most importantly, as treatment providers, the field of behavioral health needs to take our rightful place at the healthcare table, and I believe the ACA has given us a leg up to do that. And we also need to end the discrimination and the stigma associated with the patient population that we serve. Again, I think the Affordable Care Act goes a long way to doing that. This is, of course, no New Mexican ever gives a talk without showing a picture of the beautiful landscape here in New Mexico. This is sunrise over the Sangre de Cristo Mountains out our front window. And I'll just say that a new day is here in the fields of addiction. The challenges are great, but I believe the opportunities are enormous. And thank you for your attention. I'm delighted. Thank you for inviting me.
Thank you very much, Tim. As you can see, for a hard-bitten scientist, Tim is practically on the verge of giddiness as far as the potential opportunities of ACA. I particularly wanted to make sure that we had this wonderful combination of science and practice, which is, I think, very well exemplified by the partnership that we have with National Council for Behavioral Health. Mohini Venkatesh and Aaron Williams serve as Vice President of Practice Improvement at National Council and as Director of Training and Technical Assistance for Substance Abuse for the SAMHSA HRSA Center for Integrated Health Solutions. Mohini has been working in policy and practice improvement for a number of years. She serves as the staff policy liaison for National Council's network of associations through the states. Aaron, who will be speaking with her and after Mohini gets goes through a bit of her presentation, has been working with the Addiction Technology Transfer Centers before working as the Substance Use Training and Technical Assistance Lead for the Center for Integrated Health Solutions. What the two of them have been doing, and what I think is particularly important and apropos, is to show how the behavioral health field, how those of us who are working in clinical positions in management positions in the field can assist our clients to get access to care, and then also how our organizations can be can take advantage of the rapid and huge expansion of access to care that's associated with parity, with and with the ACA and with the Medicaid expansion in many states to change the way that we do business and make our services available for a much larger number of people than we have been able to serve in the past. So I'm particularly excited about Mohini and Aaron being able to talk with us. And just a reminder again that if you have any questions, either technical questions about the presentation or questions that you'd like to raise with our speakers, please type them into the chat box over on the right-hand side of your screen. So I'd like to turn this over now to Mohini and to Aaron, and look forward to really an exciting presentation. Thank you.
Thank you very much, Eric, and it really is my pleasure to be with you today and to be joined by my colleague Aaron, who'll be jumping in a little while. I also just really want to express my appreciation to Tim for sharing some important reminders with us just about the science behind the treatment services that we're talking about, and also the human element and the value that prevention and treatment can bring to the population we're discussing. Also, Tim touched upon some key policy elements of the Affordable Care Act, and really my task for the next 20 minutes or so is to reiterate some of those policy elements of the ACA and otherwise that are sort of influencing access to prevention, early intervention, and treatment services for addictions, and to relate this then down to some core practice issues that are at play in the implementation of the Affordable Care Act. So looking first at where we're at with the Affordable Care Act and parity implementation, Tim touched upon several of the comments that I'll be making over the next few slides, so I won't go into too much detail, but just want to highlight a few other key talking points and things to consider from a practice perspective. When you look at the changes that have happened because of the implementation of the Affordable Care Act, without a doubt, the incredible growth in insurance coverage or access to insurance will create fundamental shifts in the populations that are accessing treatment in different settings across healthcare, but also the way in which healthcare services are organized, paid for, and delivered. And so when you get more concrete with this, when you look specifically at the different segments of insurance coverage in the U.S., you can see that there are some key changes post-ACA implementation that are influencing the payer mix for healthcare providers. So on the slide to the left, the pie chart is pre-ACA, and to the right is post. And you can see here that there is a reduction in the number of uninsured, although not complete elimination. There's also a reduction in the number of people accessing insurance through their employer. And then lastly, there's also a reduction in the folks that are accessing insurance in the non-group or other market. And really the most specific way to think about this is people accessing insurance through the individual market. And this is a really important thing to note because historically it's been the case that when people access insurance through the individual market, it tends to be a lot more expensive for the individual, and services typically aren't as well-rounded and comprehensive. So this, while it doesn't get as much attention as the Medicaid expansion and reduction in employer-sponsored insurance has received thus far, it still will drastically change the kinds of services that people will be accessing over time. Also briefly, a discussion of the ACA implementation would not be complete without mention of changing policies at the state level as it relates to Medicaid. This slide is representing a map that's a few months old now, so you might have more updated information about what's going on in your state. But I just wanted to share this slide simply to say that so this is a continuous, moving, fluid situation, and that states still have the option, even if they have said no to the Medicaid expansion historically. That does not mean they do not have access to the Medicaid expansion in the future. And so I anticipate that in the coming years that this map is going to look quite different, and that without a doubt there are some states that are the ones that are aggressively, proactively going after the Medicaid expansion, but that's not to say that the states that are a little slower behind with the expansion aren't going to learn some incredibly important lessons about the expansion experience of those early adopters. And so this is going to continue, as this moves, it will continue to influence this payment and delivery reform that's occurring in the state. All in all, when we think about the changes from the Affordable Care Act to insurance requirements, as well as the federal parity law, we can see here that there, across different sectors of insurance options, there will be new sources of payment for healthcare services. And this is, first of all, incredibly exciting news for people, particularly who have chronic health issues. Second of all, very exciting news for folks that are typically targeted for prevention and early intervention services. And also really exciting for the provider community. I think this provides a great opportunity for providers to access reimbursement from new payers. But without a doubt, this comes with a strong tinge of responsibility and potential for new competition. That all of a sudden, having behavioral health services covered by these new payer sources will mean that all sorts of healthcare providers will think, my goodness, this is something that is financially viable to cover these services. And so it's a great opportunity for us to engage all sorts of community colleagues in this discussion about this population, and will require behavioral health providers to think carefully about their back office functions to ensure that they have the operational and administrative infrastructure to seek reimbursement from these different types of payers. When we're thinking about then all of these new insurance markets playing a role in behavioral health services, what this has the potential to mean for us, and I'll get to this a little bit later in my presentation, and Erin will circle back around as well, is that historically the population that we think is being served, particularly by the public behavioral health safety net, are folks with chronic health issues, multiple co-occurring illnesses. And what we might find over time with these new payers reimbursing for behavioral health is that there could be a shift in the population that we're serving, that without a doubt we will continue to need to provide services for those in most need of interventions for severe behavioral health conditions. But there will also be a subset of folks that are of lower acuity need and yet still have some behavioral health issues. And so we will need to think carefully then about how we plan for the services we're offering, how we market ourselves externally to other payers and providers. This slide shows that depending on your state, whether you're doing the Medicaid expansion or not, that even if your state has some takes advantage of some alternative options available in the ACA to provide financial subsidies for your state's residents when your state doesn't do Medicaid, there are still quite a few people you'll see in the peach color who are not eligible for any insurance. And this gets back to my earlier slide about how there will still be uninsured individuals in this country. And those folks may not have coverage for these services, and we still need to continue to focus on this population. So all in all, what I'm trying to express here is that we are seeing a graying in the lines of who the population is that is our target population. And this is an incredible opportunity, but will require us to diversify our knowledge base and understanding of treatment needs. Historically, the population that is typically served in a behavioral health safety net, you can see here, really in the safety net overall, are folks that are both clinically and socially vulnerable. And you know better than myself that how this creates some very complex and complicated challenges from a prevention and treatment perspective. And then when we're thinking ahead, how will this Venn diagram shift moving forward with all that we've discussed about changes in insurance? What will this Venn diagram look like? Will we still have this population within the safety net and then also have additional considerations to keep in mind? Those are really the questions that we're to turn around and inquiring with hospitals and primary care and behavioral health providers to really think carefully about their current treatment continuum, how will it fit the needs of a more diverse population base. Without a doubt, also continuing to think about, with this change in clinical need, also thinking about the operational and administrative infrastructure needed by healthcare providers to meet the needs of this diversifying client base is also something to continue to think carefully about moving forward. Tim shared a little bit of a different version of this pyramid, so I'm not going to go into a ton of detail about it. But as we all know, that there are a lot of folks that are currently accessing services for a substance use disorder, but there are many people who are not. And that we have great opportunities through specific provisions in the Affordable Care Act and other payment and delivery reforms happening at the local level to really try to help address folks that are in either in the abuse, dependence, or unhealthy use categories who could use some treatment, but also thinking about this from a prevention perspective, really trying to catch people early on so that they don't even go down this road of a lifetime of challenges and health disabilities. So there's certainly, in addition to the insurance expansion in the ACA, there are many payment and service delivery reforms that are incentivized through the ACA, and specifically things that encourage the use of rapid screening and access to treatment. And so I just want to talk briefly about a few of those elements. Tim mentioned several of these bullets, but without a doubt the fact that mental health and substance use disorder services, as well as other common treatment elements in mental health and addiction, such as rehab and rehabilitative services, the fact that these things are included in the essential health benefits is incredibly important from a stigma reduction and discrimination perspective. It is an incredible win, and we are now in the throes of understanding how states are taking this federal requirement and adapting it to the particulars of their state. And we know that there's going to have to be continued advocacy and education around this over time, because there will continue to be gaps in coverage. But from a philosophical taking a stand perspective, this is a very important transition that was made in the ACA. Also, another very important transition was that a recognition from the U.S. Preventive Task Force that there are certain services that must be covered with no cost sharing requirements. And you can see here that there are several screens that are applicable to the population of focus for today's webinar, which really is a very exciting and important transition that we are seeing being implemented as we speak. When thinking about integrated health systems, and I use this terminology to speak globally about opportunities to integrate clinically and operationally services across healthcare settings. So certainly that's called accountable care organizations, health homes, all sorts of other things. But globally, thinking about integrated health truly at all levels is trying to work towards several very important goals. And you'll recognize these elements from fundamentally what the former CMS administrator, John Berwick, used to speak about and continues to regarding the triple aim, but really trying to focus on the needs of the whole person with a focus on prevention and wellness. That you know, there are people that have chronic health issues, and my goodness, like we need to stop acting like they're broken up into pieces and thus can access care that isn't in any way coordinated from different providers. But also, how can we, with children and young adults and adults, look to prevention and wellness to really try to bend the cost curve and improve overall quality of life for people served by the healthcare system. And in order to do that, really trying to incentivize the use of team-based care, and that can be viewed both within a healthcare organization that providers are speaking to each other when they're employed by the same entity, but also enhancing collaboration across healthcare facilities is very important. And certainly no conversation about integrated health systems would be complete without mentioning the critical importance of the use of health information technology. And that's not just about electronic health records, but it's also about e-prescribing, telemedicine, all sorts of the new and novel ways in which people are using smartphones and apps to really try to engage patients in a whole new way. Also, just want to clearly say that there are specific provisions of the Affordable Care Act that are encouraging these integrated health systems. You've probably heard of many of these. There's the Medicaid health homes, which I'll be talking about in a minute. There's an accountable care organization demo in the ACA, to be clear, that's focused on Medicare beneficiaries and only Medicare beneficiaries. And then also there's a dual eligible demonstration program that's being rolled out across the country. There's also a lot happening outside of the ACA. There's just a couple examples here. So on the western part of the country in Oregon, we're seeing that state take some of the core elements of the Medicare ACO demo in the Affordable Care Act and adapt it to the Medicaid population and get a waiver from CMS to establish entities called coordinated care organizations. And we anticipate seeing a lot more of this. And then certainly the HIT Meaningful Use program was very important for that moving forward. So talking about Medicaid health homes, this is a very specific sort of interpretation of what a health home is. It is an outgrowth of many years of pockets of excellence around integrated treatment settings, really trying to think about coordinating care to meet the overall healthcare needs of people with chronic health issues. The Affordable Care Act identifies specific target populations, and another monumental success for our field was that people with mental illness and addictions were identified as a target population. And interestingly, from an implementation perspective, what we've seen is that as states are electing to participate in this, this state plan option, are that many of them are opting to focus on people with serious mental illness or addictions as their target population. So they could pick among an array of chronic health issues, and yet they're focusing on this population because I think there's recognition that the system isn't meeting this patient population's needs the way that it could be. And then also, truthfully, from a financial and systems perspective, this is a high utilizer population. And so there is an eagerness to try to figure out, can an experiment with a new way of thinking of how to finance and provide care, can it really bend the cost curve? You can see with the anticipated results, anytime we're talking about lowered rates of emergency room use or hospital admissions or readmissions, all the more important why prevention and early intervention is really, really is going to be a key factor for the success of this. And as we are involved quite a bit in helping states to implement this state plan amendment, we are seeing states attempt to use SBIRT and other early intervention models to really try to meet the expectations of CMS for this state plan amendment. Very briefly, I wanted to share just context for an accountable care organization. It's terminology that we hear a lot, and we're still, if you're thinking in the back of your mind, you're still not quite sure what an ACO is. You kind of get some of it, but not all of it. Don't worry, you're not alone. There are a lot of different definitions of what an ACO is, and truthfully, we're still trying to figure it out as we go. And so I think 5 years from now, there'll be much more concrete definitions about what an ACO is. But taking a step back, regardless of the specifics of what a certain payer source, how they're defining this thing, you can think of it as a constellation of healthcare providers all working together to meet the overall health and wellness needs of a patient population. And so that requires an incredible amount of choreography from a not only a clinical perspective, but the additional layers of thinking about the information sharing through health information technology, alignment of organizational cultures and structures, and then the ACO management element, which includes not only a governance structure, but also financial incentives to really encourage this high level of integration across treatment settings. And that's really the big difference between a health home and an ACO. It's not only about the scope, which without a doubt an ACO is much bigger in scope than a health home is, but that it really requires across-the-board integration well beyond clinical integration and simple payments given to providers. There is a greater emphasis on financial and clinical risk sharing among the constellation of providers. And through all of this, the expectation here is that really there's a strong infusion of catching the needs of the patient population early and also preventing chronic health issues. And so the expectation on all of the providers that are involved in an ACO is that they are all using prevention and wellness services because each of the providers is reliant on each other to try to keep costs low. And so what we're seeing now in the Affordable Care Act with the Medicare Accountable Care Organization demo is that we're starting to see the use of some of these prevention and early intervention strategies, and there's still some early indications we'll get to see from the ACO models that are emerging outside of the Affordable Care Act. But in looking at some of their guiding principles and governing structure, it's clear that they too are trying to encourage prevention and early intervention. And also, before I move on, want to mention that truly, if you look at the statutory language in the Affordable Care Act for this Accountable Care Organization demonstration program, you can see that there is a very strong focus on people with chronic health issues and trying to coordinate their care better, but also trying to prevent them acquiring other chronic health problems. And once again, I think this brings behavioral health providers and the populations that we're serving front and center in this conversation. Lastly, I just want to say with all of these integrated health systems, there is a this financial angle to this that not only is there an expectation that we're coordinating from a clinical perspective, but as I said earlier, a financial perspective, and that regardless of whatever payment method is being used in an integrated system, you see a few examples here, that there is a requirement that the providers that are engaged in this have a level of financial risk tolerance that historically we have not had. And with that, we'll create incentives to use prevention and early intervention services. So with that, I will stop and transition over to Erin to share a little bit more thinking ahead about what are the implications of these changes that are happening for the behavioral health workforce. Erin, are you there with us?
Oh, I'm sorry, I had you mute. So thank you guys for your presentation, Mohini and Dr. Condon. Really what I want to touch on here today is really getting into sort of at a more granular level, what does all this mean for the substance use treatment field moving forward? To really get a sense of, how, we can move forward and what are the changes that still need to, to go forward in the workplace. So there we go. So, really if you think about what Dr. Condon and Mohini talked about, essentially with the ACA and mental health and substance use parity, one of the things, more larger scale changes that are being made is really healthcare is saying that behavioral health issues, substance use issues in particular, are now going to be seen as a full partner in the healthcare process and healthcare system. Given that, there are lots of incentives around behavioral health issues and substance use in particular in the new structure. So all of that means that there will be some changes. So what kinds of changes can we think about as we look at the future here? Well, one of the things we can think about is different locations. So you have non-traditional treatment settings. With the focus on preventative services and early intervention, many services will be pushed out into the community. So you're going to have some level of substance use or behavioral health services being provided, maybe potentially at emergency rooms, community health centers, schools, infectious disease clinics. I mean, I think most of us know here the nexus between certain infectious diseases, HIV, Hep C, and substance use, and certainly hospitals. So there'll be an opportunity there to really address some of these issues out in the community and other non-traditional treatment settings. Certainly, standalone addiction treatment programs and other, larger behavioral health entities will still be necessary, still be around, but there are definitely going to be some services that are going to be, more portable services and moved into these other settings in order to address some of the mandates of healthcare reform. So what else does it mean? Well, it means potentially different skills or even different providers of substance use services. If you're going to have some of these non-traditional settings, you're going to need to have a more diverse skill set to work in those non-traditional settings. Some of the preventive services and early intervention services like SBIRT, screening, brief intervention, referral to treatment, require that you have people who are well-versed in brief counseling techniques, such as motivational interviewing, brief cognitive therapy, solution-focused therapy, and similar sorts of techniques. Given that you're going to be in these primary care or healthcare settings, the 50-minute session, in your office with the door closed may not necessarily be the bulk of what you'd be doing in these other non-traditional settings. You may be looking more at brief 15 to 30-minute sessions, with clients, as they're moving through the process, more screening, more assessment. That may be the skill set that you would need in these new settings. Also, keen knowledge of the relationship between substance use and other health conditions. If you're working in these non-traditional settings with the ACA, and as Mohini talked about, the focus there on chronic care conditions, multiple chronic conditions, and bending the cost curve and looking at those particular issues, it will be imperative that counselors and other providers have a very good hold on this relationship between substance use and certain healthcare conditions and how to address substance use in this context. Care coordination. Again, you're going to have a lot of providers who are now going to begin to be involved in the process. You have clients that are coming in that may be seeing multiple providers, or you have to work between different entities and coordinate care, particularly physical health care along with the behavioral health needs. So you definitely have to look at providers and how the care coordination is being done and whether or not your workforce has that particular skill set. Addiction treatment medications. In addition to the ACA and the other changes around mental health substance use parity, the last 10 years has been pretty good in terms of the advances in addiction treatment medications. The medications out now, naltrexone or Vivitrol, injectable naltrexone, which is approved for alcohol and opioid dependence. Looking at buprenorphine, which is approved for opioid dependence. There are a number of different medications out that are very valuable as a component of addiction treatment. These medications, though, require prescribers, require professionals that are able to either prescribe or administer these medications, and that has implications for the workforce going forward. Do you have behavioral health counselors that are knowledgeable about these medications, are comfortable talking about these medications as a treatment option? Or do you have linkages to prescribers? So if you have a client population that could benefit from these medications, do you even have access to prescribers available? Other evidence-based practices. So a number of other evidence-based practices, as you, and I'll talk a little bit about this later, as you begin and come in contact with new payers and other payers, providers of services, there's going to be a need to really diversify your knowledge around evidence-based practices. A lot of the payers are going to be looking at sort of what is there around the evidence base, and they will pay for those services. So making sure that you have a good hold of all the evidence-based practices that will help clients move forward who may be experiencing difficulty with addiction or substance use issues. New clients. So again, as given some of the context that we has been given for this, the ACA provides an opportunity to offer substance use services to more people with more varied substance use histories. Both Mohini and Dr. Condon talked about this issue of harmful users, abuse or dependence, looking at this group of harmful users, which really hasn't been a group that we focused on in the substance use treatment field. But looking at these users who engage in this sort of risky, harmful use, they may have pre-existing health care conditions or medical conditions in which their substance use is interfering with the benefits of certain medications for their pre-existing health conditions. So really looking at these different populations who may not have the high acuity in terms of abuse or dependence, but are still engaged in some level of use of substances that's probably harmful to their health. Again, when you're looking at some of these populations, for many of them, this may be the first time that anyone has ever talked to them, about their substance use. How do you, enhance motivation for change in folks who, have never had any sort of discussion about substance use and, may not be having the same sort of debilitating, effects of their use that you commonly see with folks who are in more formalized treatment. You may not be experiencing some of the life consequences that you would typically see, but nevertheless are really engaged in some sort of use that is a little outside the bounds of what they need to be doing given other sorts of circumstances. Substance users with multiple chronic health conditions. Again, this really is part of this this process here by dealing with substance use with multiple chronic health conditions, that you really want to have a skill set around this relationship between health care and the health care needs of the individuals and their substance use. You're going to have a number of people in these settings who are going to have other health conditions, and you want to have a good grasp and a good hold of those conditions as they relate to the substance use. So, in terms of training needs for the field going forward, this chart really talks about, some of the current sort of training and course requirements for behavioral health field. And really, I just put this up to kind of ask the question, about whether or not, this is the appropriate sort of training requirements given some of the changing, dynamics of the substance use treatment field and the behavioral health field in general. Payers will play a role in this in terms of, paying for certain levels of credentialing or certain levels of experience or expertise in certain areas. Is this a list of training and counseling requirements that's consistent with the new market? Maybe additional training and supports around, working in team-based care, looking at higher levels of care coordination, crisis intervention. Are these some of the things that could be added or minimally enhanced in terms of what we traditionally look at with mental health or substance use core counseling requirements? So, just to really, give you guys, some other things to think about as you move forward with some of the changes in healthcare, there really are sort of, unanswered questions fully at this point. Just to kind of think, for you to think through and consider, how will providers adjust to increase customer choice in the selection of substance use services? As Mohini talked about, more people will have some sort of health insurance coverage. Much of that coverage would include mental health and substance use services. How will the field and how will providers react when, clients operate much more like traditional consumers out in the general marketplace, when they can shop around for services? There'll be a number of other, agencies out there that will be offering some level of substance use services. So there will be more providers in the marketplace potentially, at least more choice in the marketplace, and providers really, and people, who may have substance use disorders but are much more willing to shop around for services potentially. How, will providers react to that? So to keeping with that theme, looking at how will providers make themselves more appealing to a wider variety of payers. Really looking at, a greater diversity of payers in the marketplace, private insurance, Medicaid, as opposed to some of the more traditional block grant funding. How do you make yourself more appealing to that wider variety of payer types? Do you have, are you able to really show outcomes and improvement around reductions in chronic illness, reductions in the use of other expensive services? How do you really, get on the minds of payers and look at the kinds of, things you may want to do to make yourself more appealing? How will providers outreach to other parts of healthcare to expand customer base and service array? Again, as has been talked about here, behavioral health and substance use in particular really being, asked to come to the table as a part of the general healthcare landscape. And that means, really connecting with other providers out there in the field. How are you going to do that? How are you going to begin to outreach, with healthcare providers, emergency rooms in your area, schools to come in and really offer your services and begin to increase, your customer base, your service delivery array. What sorts of services do you need to be more appealing to some of the other, groups in the community in which, you may now be asked to begin serving? How will you move forward with that process? Another point to consider here is how will providers use data to improve clinical outcomes? Do you have, that data around outcomes, around success of your clients? Do you have, the ability to engage in some level of population management? Can you, really, tell your story through data to other payers, providers, and other, people in the community? Do you have that sort of infrastructure, electronic health records, registries, and others that can provide you with that useful information, for you to go forward? Now, really, put that out there as kind of, considerations for the group around the way forward for the addiction treatment field, given some of the changes. Like Dr. Condon, I'm very excited about these changes. I think they offer an opportunity, to provide services to a much larger, section of the population that may be in need of these services. I think the services are very transferable to a number of these different, locations. I just think that the field needs to make sure that they're prepared, to move forward in that way. Just a quick comment here with a number of resources really quickly. A couple of things that we have done here at the Center for Integrated Health Solutions. We have a document, Innovations in Addiction Treatment Providers Working with Integrated Care, that really talks about and discusses, how some providers out there are integrating healthcare into their addiction treatment services. We also have an online course that we did in conjunction with the Addiction Technology Transfer Centers, where we really kind of discuss, what is it like for substance use professionals to work in the primary care setting. Some other really quickly resources, the National Registry of Evidence-Based Practices run by SAMHSA, which is a great resource if you're looking for new evidence-based practices around substance use. CIHS also has a screening and brief intervention clearinghouse that gives you a number of different resources around SBIRT. And I also did want to mention the BH Business learning collaborative that's being done in conjunction with NIATEX and the National Council, which really helps providers think through some of these issues around payment reform and other sorts of structural issues that may be affecting the service delivery and really helping them move forward as the ACA and healthcare reform continues. So with that, I will turn it back over to Eric. Thank you.
Having to work the technology. We have a good number of questions. We may not be able to get to all of them. So if we don't get to have your question addressed, we will do our best to get back to you offline. So there are a number of questions that have come up over the course of the discussion. One, Anna Veria asked, can you address co-occurring disorders and how ACA covers those populations? And I assume that means co-occurring mental health and substance use, although it could also be mental health, substance use, and medical problems. Is there anything specific about it?
Sure. So this is Mohini. I'm happy to take a first stab at it, and other presenters can join in as well. So there really, the Affordable Care Act does not get to the detailed level of providing specific provisions or allowances for certain populations based on diagnoses. So there's nothing explicitly in the ACA that outlines what are the services or benefits available to people that have co-occurring mental health and addictions issues. However, that doesn't mean that there aren't provisions of great benefits to them. One of the great challenges that people with multiple health issues face are, from an insurance perspective, they hit all sorts of annual and lifetime limits. From a clinical perspective, there's a lack of provider coordination, so they have to repeat what their health conditions are, and there might be all sorts of issues around their medications being counterindicated. And from a financing perspective for the providers, there are all sorts of challenges around being able to bill for the different kinds of services that that person might need. All three of these things are directly addressed by the provisions that were described during today's webinar. So Tim had shared that there elimination of many of the insurance benefit limitations that are available to people now. There's all sorts of provisions with integrated health systems to try to promote provider coordination and communication about what's going on with a specific patient. And then without a doubt, there's restructuring of how services are paid for to encourage providers to speak to each other a lot, to coordinate care, and to make sure that the person's overall health and wellness is being met.
Okay, thank you, Mohini. Perhaps also Mohini, but Aaron, you might want to comment on the next question, which is, I think, goes to what this whole expertise that many of us have developed around CPT codes. Does ACA change billing codes for behavioral health services? Will it remove any of the barriers to current services use, such as the difficulty of charging for a behavioral health service on the same day as a primary care visit? Does ACA have anything to do with how you actually bill as a provider?
Mohini, do you want to take a shot at it first, and then I can?
No, Aaron, go ahead. Go ahead.
Okay. So, well, I would say that in terms of my thought about it is that the ACA has sort of an indirect effect on a number of these different things. While, specifically, I don't know if the ACA actually changes a billing code. Given some of the mandates and some of the requirements within the ACA, a number of different states across the country are beginning to look at some of these issues that are creating these kinds of barriers to working through an integrated or more formal process. So states are looking at these kinds of same-day billing issues. Medicaid and Medicare are looking at sort of fixes to that, and I think there was some guidance issued around that that came out from CMS. But there are a number of states who are beginning to consider, who is an eligible provider for certain services like SBIRT, and looking at how they can make some tweaks and adjustments to these to really kind of move themselves more in line with the larger goals of the ACA. So I don't think ACA.
So what you're basically saying is that ACA itself doesn't get down into the weeds, but with the changes in access to insurance and Medicaid, it's becoming clear in many states that they're going to have to make changes in, say, same-day billing.
Yep, exactly. I think there are a lot of states where there's a lot of energy around changing some of those policies and practices at the state level, and I think ACA is a big facilitator of that.
Terrific.
Eric, I might add into that working with the behavioral health department here in New Mexico, that's exactly one of the issues that's on the table. And it is in the weeds, but it's so critically important. Don't have the solution yet, even in a small state like this, but that is something that everybody on the call should be involved in, should be advocating for, and get involved in those discussions whenever appropriate.
I think one of what I'm seeing from the questions is how does it affect me, and how, what do I have to do? The next question comes in is, does ACA define or have an impact on the type of behavioral health professionals who are eligible to provide services? For example, we've heard that current addictions counselors will not be reimbursed under ACA. Is that true? I think we're here silence. I think the overall. Go ahead.
I was going to say, so I mean, again, some of these, I think, the ACA is kind of a very large piece of legislation, but some of these decisions are actually going to be made at the local level. So some of this may not necessarily be directed at the ACA per se, but much more at the local level. There are some issues around how this shakes out around certification and licensure, and which sorts of providers will be insured or will be covered through Medicaid for certain services. But that's not necessarily an ACA issue as much as it is being determined on the ground by states and state Medicaid authorities and the like. So that issue is out there. I mean, I do understand where they're coming from with that, but that sort of remains to be seen as to how that'll work out.
Thank you. That really fits with the point I think that Tim was just making, which is a lot of these decisions are being made at the state level, and that it's important to be involved through your provider association, through your organizations in making these decisions. Another question. Yes, go ahead, Mohini.
If I could just add really briefly, just 30 seconds, for some context here as well, that you know, all of us on the line today are very much in the weeds and details of looking through all of this around the addiction workforce and their eligibility for participation in all of these provisions we've talked about today. But it's important to note that these challenges are challenges that are being experienced across the healthcare sector. So it might not be the specifics or the same level of staff, but this idea of ensuring that all the levels of staff in various specialty sectors are included in the ACA. I hear it across the board in meetings with all sorts of other specialties as well. So this is an honest implementation challenge as well with the ACA.
Thank you. Does ACA impact confidentiality issues around electronic medical records? Any impact on 42 CFR Part 2?
Very briefly, there once again no direct provisions that are speaking to this, but there's a whole incredibly intense policy dynamic around the possibilities of changing it, and I think that conversation, that dynamic has been accelerated by the provisions in the ACA that are trying to encourage provider coordination and collaboration.
Terrific. I'm aware that we're not going to get all of our questions answered. One question that came up, and maybe you can address this briefly, is what support is available now to help substance use treatment programs, behavioral health treatment programs, to become eligible to accept Medicaid and the influx of the newly insured patients or clients? And this really, I think, goes to the Business Academy.
Yeah, thanks, Eric. I appreciate that. This is a great question, and it's one that I'm sure we all get very often. There is a free online resource being made available through SAMHSA. It's called BH Business. Some of you on the line might be familiar with this initiative. We're in our second year, and the idea with this program is to engage hundreds of healthcare providers focused in mental health and addiction populations to educate them about the back office business operation functions that are needed to excel in sort of a health reformed environment, and that certainly includes Medicaid billing, but also contracting, strategic business planning, and several other curricular areas. If you want to learn more about that, you can go to bhbusiness.org, and applications are currently open for that, so I encourage you to check it out when you can.
Thank you very much, Mohini, and I want to thank everyone, Tim Condon, Mohini, Venkatesh, and Aaron Williams for a really terrific presentation. If you were interested and would like to download the slides in a PDF form to listen again or to suggest to others that they listen to this presentation, or to get other materials including continuing education credits, the website hospitalsbirt.webs.com, and then this specific webinar is the acachanges.htm. There also is in the sidebar that you hopefully you'll notice is that there is a pop-up quiz that or a questionnaire that it's something that we need for our own funders. It is, if many of you are familiar with GIPRA, we need to know whether this webinar was useful to you, what we can improve, what you got out of it, not in terms of a test that you learned, but rather, did we get and answer the kinds of questions that you have about ACA? Again, I want to thank everyone. I want to thank our presenters. I certainly want to thank very much Misty Story for helping us technically put on a really terrific webinar, and I want to charge everyone to go out and do what they can to enroll people in health exchanges and in Medicaid so that they will have access to the kind of choice that others of us have had through our health insurance to get access to care for their mental illness, for substance use, and their medical problems. So thank you very much for participating in our webinar. I look forward to working with you, and please look at the list of the webinars that we have coming up, and I hope that you will attend as many as possible. Thank you again from the National SBIRT ATTC, NADAC, National Council, and the BIG Initiative. Thank you. And we're out.
The organizer has ended the session, and this call will be disconnected. Goodbye.